Very nice seeing all of you today in our World Institute of Critical Care and Emergency Medicine Neuro-Critical Care webinar. Neuro-critical care is a life-saving medical specialty dedicated to manage acute and severe neurological injuries and diseases. And it bridges the gap between neurology, neurosurgery, critical care physicians, emergency medicine physicians, and it ensures that patients with devastating brain injuries and spinal cord conditions receive timely and evidence-based multidisciplinary treatment to improve their outcome. Well-trained neurocritical care physicians save lives in time-sensitive emergencies, as many neurological crises require immediate intervention. Neurocritical care experts manage complex, high-risk cases that most doctors are not equipped or trained for. The neurocritical care training addresses a growing global health crisis, and investing in the neurocritical care field and the training means investing in the future, where brain injuries are no longer a death sentence, but a treatable and reversible condition. The World Institute of Critical Care and Emergency Medicine is very happy to launch and announce its own fellowship, which is online fellowship in neurocritical care field. And because we know that our retention rate is very low when we teach lectures or read articles or books, we try to use audiovisual demonstration, clinical case discussion, practice, and involve our clinical case scenarios and real life cases in our education to improve our knowledge. This online one-year fellowship is structured as 3 modules, 16 weeks each. It's real education, not based on only webinars or seminars or recorded lectures. It's a dialogue, not a monologue. So we involve our fellows in the education process. There will be thousands of questions and answers, evaluation and assessments, critical thinking and appraisal, and we gathered a panel of international expertise. Again, it's 1 year wholly online fellowship program, and it will have also a lot of workshops, live webinar, video conferencing. All of our scientific materials are released on weekly basis in a smart platform, and all fellows will have the freedom to navigate throughout the scientific material within the week of educational material. Then they need to submit their tasks and assignments before the end of each week. There will be a weekly quantitative and qualitative assessment, not only based on the knowledge, but also based on the engagement and activities of each fellow. Upon completion of the program, fellows are expected to be experts in the neurocritical care field, graduate to trainer, mentor level, and receive American accredited certificate for completion of their fellowship. And because we know that knowledge has no value unless we put it in practice, and because the great aim of education is not the knowledge itself, but the action, we are aiming to improve our patients' care and outcome by training and educating high-quality neurocritical care physician. Again, today is our first webinar among of several webinars we are going to conduct in the next 6 months. We have great speakers, moderators. We have Dr. Kara Roba, Dr. Walid Jassim, Dr. Ashraf Tayyar, Dr. Manzoor Ahmed, and Dr. Bastian. And here is our agenda today. We are going to start with the first lecture of Dr. Manzoor Ahmed, Neuroimaging for Intensivist. Then Dr. Kara Roba and Dr. Walid Jassim are going to handle the question and the answer and moderate the session with Dr. Manzoor. Then we'll have another presentation from Dr. Bastian, Brain on the Fire, with very interesting case that we see all the time in our ICU. And the discussion and the QA box will be handled by Dr. Ashraf Tayyar and Dr. Fadel Ibrahim. The closing remarks are going to be given by Dr. Walid Jassim. And now I'm going to stop share and will let Dr. Walid Jassim to introduce our first speaker, Dr. Manzoor Ahmed.
Thank you, Dr. Amr Al-Husseini. It is a pleasure to have company with this panel of a group. I'm also very much pleased to introduce my colleague and my mentor in neuroradiology and my professor in neuroradiology, my close friend, Dr. Manzoor Ahmed. Dr. Manzoor Ahmed was trained as a neuroradiologist in the US, worked long years in Cleveland Clinic in US. Then he was transferred to Cleveland Clinic Abu Dhabi. And at my hospital, Sheikh Khalifa Medical City, we were very lucky that he was transferred from Cleveland Clinic Abu Dhabi to Sheikh Khalifa Medical City. Apart from being a very pleasant person and a very knowledgeable person, Dr. Manzoor Ahmed is very well known of his love for teaching. He is now a regular speaker in all Middle East and Gulf radiology conferences. Dr. Manzoor, the stage is yours.
Thank you very much, Dr. Amr and the organizing committee, and special thanks to Dr. Walid for the kind introduction and opportunity. So it's going to be mostly pictorial presentation. As you know, I'm a radiologist. These are my objectives, and the focus is on CT and MR imaging, no financial disclosures. Let's start with something more practical. We call it non-interpretive radiology or hidden curriculum, especially important for in-house physicians. We always inculcate that we should treat the patient, not the picture, in the true spirit of good clinical practices, and not to pull the trigger just based on report, as it can really cause problems. And better look at the scan yourself too. It will really add to the safety net. Remember, we radiologists literally in the dark room and dark about the patient information. So we should work together as a team to help the patient care and to be safe. And appropriateness is extremely important in radiology. First, determine whether the study is even needed or not, and which is the right modality. CT is a high-dose modality, we all know, and should not be abused and should not be used just like chest X-ray. And on the same token, we should throw away the fear factor about radiologic CT contrast specifically, as there is a fear factor and it delays the patient care. In most of the time, it is safe. And in the acute setting, we should just go ahead and give contrast. And on the other note, MR safety regarding methods and devices, again, misconception. We think everything is unsafe, which is a wrong concept. Most of them are safe. It will prevent delayed care of the patient. And lastly, we need patients who are cooperative to result in optimal scans, and we count on you. So first thing first, let's start with normal CT and MR head imaging. How to approach these scans? CT has a significant value. Over the years, we have developed it, and we have to extract value of CT. It is so accessible. So CT images you will see in different filters and windows. Brain images for brain structures, then bone is for fractures, as you see here. And you can play with the display windows, and you can see here is a subdural image for detection of subdural hematoma. So windowing is extremely important. What you notice here is a circle, which is the ROI, and we can characterize the lesion even on CT based on the CT number. We call it Hounsfield unit. For reference, 0 is water, 0 up to 20 can be liquid or aqueous. But if the lesion, for example, has minus 150 mean value, then it is actually fat. And if it goes further down in a negative value, then it would be air. And CT bones, for example, would be much higher, up to 1,000. So we should be familiar with CT numbers to characterize lesion. So this is one of the major take-home message. Try to window images and try to draw a region of interest. So this is just to showcase multi-planar capabilities of CT. You can have orthogonal and non-orthogonal images. And the take-home message, use all your tools, don't be fools, and look at all these available sequences and lines. And let's showcase the value of CT in the form of these sophisticated images. As you can see, color 3D imaging of the skull for detection of skull fracture, as pointed out here, CT perfusion images. Furthermore, we have neurovascular, other vascular color-coded images. And not to forget, in the last 20 years, we have developed a portable CT for cardiac critical care patient. And what we have now in MRI, actually, we have portable MRI out there in some institutions they are using for head imaging. So we are really moving forward. What is standard MRI brain look like and how to approach it? So these are the 5 major sequences you will see. T1 we start with, it is made for the midline structures. As you see, T1 CSF would be dark in color, unlike T2 images. And we see an example, a midline large mass, pituitary macroadenoma. Axial T2 is a multi-purpose sequence, and it has CSF, which would be bright color, and it would be identified for T2 imaging. And as an example, you can see bilateral basal ganglia edema in a metabolic encephalopathy case. And then we have T1 multipurpose image, and typically we use it for bright lesions, for example, subacute blood, or it can be fat sometimes. So we should be familiar with some of these lesions which are bright. And then axial T2 flare imaging, multipurpose, and it is T2 except the fluid is suppressed. It was invented for white matter pathologies, as you see a case of ADEM. And then the last one is the axial GRE, or susceptibility weighted image for detection of blood, typically chronic hemorrhage, lobar hemorrhage with microbleeds in a patient with hypertension. Even calcium can be dark. But what is missing here is our hero sequence of MRI, which is diffusion imaging. But when we look at diffusion image, we call it a diffusion image or B1000 image. Anything bright is going to be cytotoxic edema, and this is a thalamic infarct, but you have to confirm on ADC maps that it is dark, bright here, dark here. And what about surrounding area? So the infarct itself represents cytotoxic edema, but surrounding is vasogenic edema, which we call facilitated diffusion. The infarct itself is restricted diffusion. It is a crucial critical care sequence and should be the first sequence. But what they say is all that glitter is not going to be gold. So here we have an example of seizure-related diffuse cortical signal not following the vascular territory because of seizure. It can be bright. It is also cytotoxic edema, or it can be excitatory related edema. And then we have abscess, which has peculiar appearance, very bright on diffusion with rim enhancement, and even tumors can be restricted, as you see here, a case of lymphoma. So 3 etiologies you should keep in mind: cytotoxic edema, pus, and hypercellular tumor can be restricted and bright on diffusion. So do we always need contrast, especially in acute or ICU cases? Actually, the answer is no. And If you need to give contrast, particular CT or even MRI, both are very safe, as I alluded to before. But when do we need contrast? Particularly when we suspect leptomeningeal disease, that we should give contrast. What about encephalitis? Here we have a case of herpes encephalitis, typical mesial temporal lobe involvement. And it is a rule rather than exception that encephalitis usually not enhancing. Later on, it may enhance. Even meningitis, we don't have to do MRI. It's a clinical diagnosis. But in meningitis cases, we will see meningeal enhancement. This is a classic case of TB with diffuse nodular and rim-enhancing leptomeningeal disease. So in leptomeningeal disease, malignant or benign, contrast definitely has a value. So let's start with our first case, which is a composite case. And before that, let's localize the hemorrhages in the brain: ganglionic, lobar, and posterior fossa. So composite case number 1, 3 Filipino patients, a Filipino background. They have a high incidence of hypertension. So we have case number 1, lateral basal ganglia, but small hemorrhage. Lateral basal ganglia, but large hemorrhage. Look, we did a ROI, and the blood values, acute blood, is between 60 and 80. And then the third case is actually gangliothalamic central hemorrhage next to the ventricular surface. So it ruptured into the ventricle, causing blood in the ventricle as well as hydrocephalus. And additional features of hypertensive hemorrhage: you have a large brainstem hemorrhage with fluid level, which means there is acute bleeding or there is anticoagulants underlying. And furthermore, we have more examples that we have cerebellar hematoma, even intraventricular and basal ganglia hemorrhage, multifocal. So non-traumatic cerebral hemorrhage, as we know, it's 15% of strokes. It's high mortality, particularly when patient on anticoagulants. Hypertension is the most common cause. Other vascular causes can cause that. And important to remember, hemorrhagic transformation, as we'll discuss stroke, patient selection is key, as we want to have to be of utility rather than futility. Venous infarct can also look like this with teardrop subcortical hemorrhages. So it is not always hypertension as the primary cause of hemorrhage. There can be other causes, at least 2 of them I will show you here. So look for certain additional or atypical features. We have calcification with hematoma and large vessel. You can predict it is going to be a large AVM. And what else? Where here we have a large lobar hematoma with surrounding edema. And when we give contrast, rim enhancement, so this is going to be a GBM. So look for additional features. It's not going to be always hypertensive, particularly lobar hematomas. So few pearls about hemorrhages. As we know, look for intraventricular extension as because of proximity. Monitor progressive hydrocephalus. We don't have to do CT in most of the ganglionic hemorrhages. And look for subtle periventricular ganglionic focus into intraventricular hemorrhage, as that may be the primary source. And when you have non-ventricular subarachnoid hemorrhage plus parenchymal hemorrhage, as in this case, you would think it's a basal ganglia hemorrhage. No, this is actually a rupture of the MCA aneurysm. So this is not the primary problem. The primary problem is the diffuse subarachnoid hemorrhage. So we have to be cognizant of that. And we should be careful with ganglionic calcification, and we should be able to predict hematoma expansion, as I will elaborate here. So what are the few factors which predict hematoma? First is the size. As you see, this patient underwent decompression because of the large size and growing hematoma. Other things we should look at the characteristic of hematoma, these patchy high pore densities, dark areas with different names, or if you do CTA, these bright spots, these are vessel extravasation of the contrast, and we call it CTA spot sign. They predict hematoma expansion, and a fluid level also predict hematoma expansion. So furthermore, some pearls and pitfalls. This is typical hematoma, lobulated irregular margin, but on the contralateral side, this is actually calcification. Pick up your ROI and do the Hounsfield units, and you can see that this is about Hounsfield unit of 100. And on the right side, we have also asymmetric basal ganglia calcification, really confusing, and bilateral calcification. So pay attention to surrounding edema and do the Hounsfield units. So there is a large ventricular hemorrhage. Actually, the cause is periventricular parenchymal hemorrhage, so we have to look for that. Furthermore, there is a focal hyperdensity. You would think it is a hemorrhage. Actually, it is a typical appearance for cholestasis, non-dependent, sitting in the anterior third ventricle. Furthermore, you have tumor which can be very, very hyperdense and can look like a hemorrhage, but these are hyperdense hypercellular hemorrhage. This is medulloblastoma, and this is actually lymphoma. So take-home message is not everything bright on CT is going to be acute blood. So case number 2, which is going to be our major focus of discussion, is 50-year-old female presenting with sudden right-sided weakness and slurred speech. NIH stroke scale you are probably more familiar with, and this is a pretty high score, moderate score. So CT was negative. So the take-home message is better selection is key for in case of thrombolysis and thrombectomy, and accurately determine dead tissue, which is the infarct core, and the dying tissue, which is called penumbra. This is a busy slide, but that's the approach I use, the T approach and P approach. So the T approach, we will focus on few things only, the tube imaging, tissue imaging, and of course the time window, which is very important. And here is our case. So aspect score is the early ischemic determination on CT. We will talk about it in the next slide. So a score of 7 is good out of 10, and M1 occlusion, confirm on catheter angiography, high-grade stenosis, and the neck, which sent the embolus. And then thrombectomy was done successfully and opened the artery. Remember, patient has good collaterals, the infarct stayed the same. And this we call at slow progressor, give us the time window for treatment due to collaterals, and in NIH stroke scale improve from 10 to 3. So let's go back to the aspect score from Alberta, and now the AI software is available. They will do it for you. The MCA distribution is divided into different segments. And you see here aspect of score of 7, 10 minus 3 is 7. So 3 segments were involved. It's a good score. Above 6 is a good score. So what is the other tool we can use? And actually, if I have the option, I will do MR, but access is the issue. Diffusion is your most reliable tool. As you see, diffusion B1000 image, large infarct, bright and dark on ADC classic. It is the most reliable tool, literally in black and white answer, and should be the first sequence actually in any critical care patients, and positive in minutes for infarcts. So let's go back now to understand the penumbra. So we know the infarct core, how to determine. What about penumbra? So penumbra is the salvageable tissue. Here is a large infarct, and perfusion shows there is no salvageable tissue. It matches the dead tissue. So we call it a match defect, but this is not favorable. The favorable scenario is here we have right M1 occlusion, tiny infarcts, but large penumbra which can be salvageable, and that's the classic target case for thrombectomy. So how we determine now on CT, and this has really been a game changer in stroke imaging in the last 10 years, rapid software or other softwares, which will determine penumbra in exact precise numbers. So this green area is the hyperperfused area, and you subtract the infarct core based on CBF maps, and it will tell you that 76 cc is the salvageable tissue. So the job is being made so easy now. CT is one stop, one shop. You can do multi-model imaging. What is penumbra? Penumbra is the tissue at risk, which is the dying tissue. It has tough functioning, but it can be reversed. So again, it's a busy slide, but just focus on few things. Divide into less than 6 hours and more than 6 hours. And this is the time frame. If less than 6 hours, rule out hemorrhage, determine large vessel occlusion like we saw M1 occlusion or IC occlusion or M2 occlusions, MCA branch. and or basilar artery, and then the patient is taken to thrombectomy. Yes, the patient will be given thrombolysis based on non-contrast CT when there is no hemorrhage, unless there is a contraindication. But patient will go for thrombectomy if there is a large vessel occlusion. What about patient presenting more than 6 hours? Then the game is different. Now you have to do really penumbra imaging. You want to be more selective. That's why it's important. So take-home message image-based patient selection is key. Thrombolysis less than 4.5 hours, irrespective of anything else. Thrombectomy less than 6 hours straight away if there is occlusion. But more than 6 hours, up to 24 hours, actually you have to be selective. And what do we need? We need small infra core, small dead tissue, and large salvageable tissue. Very simple. Time-based, tube-based, tissue-based approach. And we need slow progressor than rapid progressor, and that is mainly because of collateral. So composite case number 3, 2 different patients, and they are sent to rule out brain death as clinical assessment may have questions. So they were resuscitated, but not doing well. So can CTA do that job? And catheter angiography has been the gold standard, but there are ancillary tests which varies in different countries. So we have 2 cases, and you can see the obvious findings: diffuse cerebral edema with hypodense brain parenchyma, loss of sulci, fissure, and basal cisterns. And what else? Loss of gray white matter differentiation, and the ventricles are compressed. So always look for the CSF spaces as we see here, and this would be representing diffuse cerebral edema. What do you think of the hyperdensities around the brain parenchyma? So here is a much better example, as this is case number 2, and diffuse cerebral edema, but looks like pseudo subarachnoid hemorrhage. That's why I pester my PGY1 and they call it subarachnoid hemorrhage. Actually, it's pseudo subarachnoid hemorrhage, and this is because of dense congested venous system due to outflow resistance. And this is diffuse edema, which result in cerebrovascular resistance, and the CTA would be very helpful. So clinical assessment, we know plus apnea test is supreme. And these are the 3 tests which are well established. But what about CTA? Well, I would sell the case of CTA here. CTA is an easy, accessible ancillary tool, particularly if clinical assessment is questionable and unclear and challenging. And we can use different point scoring system depending on the visibility of vessels. The technique is important. CTA should be 2-phase, 20-second, but 60-second scan is very important. We need specificity. We don't want false positive cases. CT perfusion is not well established, so CTA is the one we have to use. There is a guideline from UK recently, consensus guidelines, and we should use 4-point system. What does that mean? So here is a case, and post-asphyxia, diffuse cortical injury, but no diffuse mass effect and edema. And even globus pallidus is typical for carbon monoxide poisoning. This case was strangulation. But what is important is in this case that we saw before, diffuse edema, unequivocal. But we see M4 and internal cerebral vein, all 4 vessels for the 4-point system. It does not meet the criteria. So we cannot say it's brain death by neurologic criteria. So what should we look at? Another case, and that was our case number 2, diffuse cerebral edema and pseudoarachnoid hemorrhage. Here, the carotid, there is no antegrade flow. That's where it meets the 4-point criteria. The vertebral one, the delayed imaging, I'm not showing here, they were positive. So this is a case of brain death by neurologic criteria, and the CTA would be helpful in this case. So there was antegrade flow arrest, and that's what we are looking for. So after that, let me quickly show you how hypoxic ischemic injury appears. And you can see bilateral basal ganglia, caudate, putamen, restricted diffusion on ADC maps, and bilateral perirolanthic area. So these are the 5 areas we look for. There can be combination or there can be isolated injury involvement. But the take-home message is hypoxic ischemic injury, there can be spectrum of pattern of findings due to prolonged and or profound insult. Moving on to our case number 4, and this is a 33-year-old collapse patient after complaining thunderclap headache, and you can predict what will be the finding. So let's do non-contrast CT and CTA. And the findings are obvious. There is diffuse subarachnoid hemorrhage, and it is aneurysmal unless proved otherwise, and even the patient has hydrocephalus. CSF space is full of hyperdense blood. So how to approach CTA and make it a habit that you look at the axial source CTA images first, and we see tiny aneurysm, and you can confirm those on the multiplanar images, whether MPR or MIP, maximum intensity projection, which makes the dense structure very bright as a reconstruction. And here we have a 3D image. This is the internal carotid artery aneurysm. This is ACSO2 aneurysm. One of them has ruptured, and it needs to be coiled. Take home message, always look at the source axial images plus more than one plane, including 3D images. So the coiling was done, as we see here in the catheter angiography. Before that, confirm the aneurysm. So urgent coiling is now standard of care, and patient would need EVD if there is hydrocephalus and to drain the blood. And it is not always going to be saccular aneurysm, actually. It can be fusiform, like we have vertebral artery dissecting saccular aneurysm. And few points about acute subarachnoid hemorrhage is that it is not going to be aneurysmal all the time. Traumatic is actually more common, and high mortality rate, high rebleed rate, and CT is very sensitive as the MR, and CT is very highly sensitive for picking up the aneurysms. ACOM, ICA, and MCA, the common location. You see traumatic subarachnoid hemorrhage, usually localized, and actually it's a negative prognostic marker. So look for associated hydrocephalus, and you know the Fisher grading, but now we have modified Fisher grading, as you see here. And it is the concept behind it is there are 4 grades that it has to predict the vasospasm and then infarct, which determine the prognosis. So thin with ventricular or without ventricular hemorrhage, as well as thick and the same presence of hemorrhage in the ventricles. So this is a really useful grading system. Let's be aware of that pseudo-subarachnoid hemorrhage I showed you before, and sentinel bleed or sentinel headache. These are warning bleeds, and it would be a golden window if we can pick it up before it makes massive rupture. And benign perimesencephalic hemorrhage is just blood around the brainstem, and patient would really do well, and they would look good. Traumatic central subarachnoid hemorrhage, not uncommon. When it is central, be suspicious that there may be underlying aneurysm which ruptured, and even aneurysm can cause subdural hemorrhage. So case number 5, a patient had a fall with GCS of 8. We have a CT, large hemispheric acute subdural hemorrhage, as you see here, and with mass effect. So scalp hematoma and Fox, there is blood extending to the Fox, typical for subdural hemorrhage, and no contralateral subdural hemorrhage. And there is even deeper hemorrhage, which represent traumatic axonal injury. But what else? There is strapping of the left lateral ventricle. All this because of the displacement and mass effect. Cingulate gyrus is displayed, which we call midline shift, and mesial temporal lobe is shifted, which we call uncal herniation. So it's good time to discuss brain herniation syndrome. Subfalcine or midline 15 millimeter is a negative prognostic marker. And what happens is the secondary effects, particularly vascular compromise or effect on brainstem. So we have an AC infarct because of the midline shift. And we can have also uncal and central herniations. The whole diencephalon can go down transtentorial, and it can cause PCA infarct or mass effect on the brainstem here. Or here we see that it can cause diurete hemorrhage because of transtentorial herniation. And we can have tonsillar herniation with mass effect on the brainstem. So also we can have paradoxical phenomena, sinking skin flap syndrome, as you see here, and it can cause mass effect in post-craniectomy patients. And intracranial hypotension, ironically, it can cause mass effect by having subdural hemorrhages due to low pressure or subdural collections. And lastly, if the uncal herniation push the brainstem, cerebropeduncle will be pushed on the opposite side in the Kernohan notch, giving you false localizing sign. Few rapid fire cases in the last 2 minutes. So these are the diffuse cases. What is common among them is diffuse, confluent, symmetric, mostly white matter involvement, and usually reversible. There's one entity I'm withholding. And this is the case, 65-year-old, hypoxic episode, opioid dose, recovered, but after 21, 22 days, patient had deterioration. And why is that? This is a case from literature, but very interesting. And you can see diffuse leukoencephalopathy, diffuse restricted diffusion in the white matter. And this is a rare entity, less known. After initial improvement or resolution, patient gets worse. And this is because of the 21 days time in which there is myelin turnover. This is diffuse demyelination, and the entity is called delayed post-hypoxic leukoencephalopathy. In the next case, very similar pattern, mimics the other one. And what we see, diffuse leukoencephalopathy, but this is a this is toxic leukoencephalopathy. Then we have another toxic encephalopathy, but now bilateral cerebellar peduncle. The key is bilaterality and symmetrical pattern, corticospinal tract. And here we have bilateral basal ganglia changes, metabolic. Here we have a methanol injury, and typically it also involves basal ganglia. So they will almost, most of them will look very similar, but symmetry and bilaterality is the key, and confluent signal changes. This is my last case, typical press case, posterior dorsal symmetric subcortical white matter changes, usually hypertensive patients, but there can be a range of findings. Believe me, press has so many patterns and phases, atypical, asymmetric, and then hemorrhagic. It can be restricted. It may not be reversible, most of the lesions, and it can enhance. And here we go. We have a central atypical press, brainstem and cerebellum, and it normalized in 1 week. So press, the take-home message, can have a variety of atypical patterns. So with that, thank you very much for your kind attention. I hope you learned.
Thank you very much, Dr. Manzoor. This is very informative and excellent lecture, and you took to time, 30 minutes exactly you took, as we agreed. I opened the subject for questions. I didn't receive very important question. I leave my colleague, Dr. Kaira. Dr. Kaira, can you ask a couple of questions? Yes. Do you want to ask a couple of questions to Dr. Manzoor?
Yes, Dr. Manzoor. So there is a question from the audience, which I think is quite interesting. So it says, in critically ill patients, when there is no possibility of transportation to CT or MRI, do you think that the optic nerve sheath diameter ultrasound to assess cerebral edema, or I would add in general brain ultrasonography, can somehow help, can provide information in these patients? What do you think?
Thank you very much. I hope you can hear me.
We can hear you very well. Go ahead.
So I think the question is a little bit offline, off track for me. Maybe my colleagues can answer that, because we don't do ultrasound. The question is about ultrasound, correct?
Yes, ultrasound in Neuro-Critical service.
Yeah, so that is actually, I personally, we don't do that. We mostly deal with CT, MRs, and maybe any colleague can answer that who does. I would assume this is a point of care kind of evaluations. So maybe somebody else can comment on that.
We will arrange a lecture about that in the future, but I will ask you a more simple question, if you agree with me, Dr. And this will be the last question, because we need to pass on in 1 minute, 2 minutes. My question, every time they say there is no good stroke service without an MRI, Can you explain in a couple of minutes why MRI is so important in stroke service, and what is the difference between CT and MRI? In a couple of minutes, please.
Okay, so this is a very important question, and that's why I focus on CT because of the accessibility. But if you have MR access within minutes, because time is brain, so I would tell you that MR can be very, very effective. We in Cleveland Clinic do studies about 15 years ago that if you use MR as a first modality, your mortality rate will improve, your futility rate will go down, because we will not be doing futile thrombectomies. So MR is one of the best choice because it shows black and white. Your diffusion imaging shows infarct core. So MR is very powerful, but the main issue is the access and the time. So we don't want to lose time. Now they have brought up the CT with perfusion so we can accurately determine infarct core and penumbra. So that's why everywhere they are doing CT. Main difference is the access. MR has the access limitation. If we conquer the access, I would say MR would be supreme.
Thank you very much, Dr. Manzoor. We finished the 5 minutes of a question time. Now it is 20:45. I will hand the podium to my colleague, Dr. Fadel, to introduce the next speaker.
Thank you very much.
Thank you.
Dr. Fadel, you are muted. Dr. Ashraf.
Yeah, thank you very much. Gives me a great pleasure to introduce the second speaker, and probably Dr. Fadel will handle the question to the second speaker. The second speaker is Dr. Bastien Termoulin, and he is from Netherlands. He studied medicine in both Belgium and Netherlands and completed his fellowship and training in neurology in New York in the United States of America. He is well-known neurologist at King's Hospital in Jeddah, one of the new prestigious hospital in Jeddah, King's College Hospital. And Dr. Bastien will be kindly asked now to start his presentation on a very interesting, commonly seen case in ICU environment. So please, Dr. Bastien, the floor is yours.
Thank you, Professor Ataya, for the very kind words and introduction. Yes, I am originally a Dutchman, and I just landed here in Jeddah, Saudi Arabia, like 3 months ago. And I'm going to present an ICU case. And the title of my lecture is Brain on Fire. And I think that the title says all. So the case, let's see, is one on NORSE. So that is the new onset refractory status epilepticus, which is a quite devastating status epilepticus that is very hard to treat. And another term that is often used is FIRES. It's also an abbreviation, and FIRES stands for the febrile infection-related epilepsy syndrome. So these terms are quite overlapping, and I will focus on that later on. So the objectives of my talk are to know what a status epilepticus is, to know the use of the continuous EEG monitoring, and to become familiar with these two terms, NORSE and FIRES, and also to learn about the structured approach to these patients. It's a rare condition, but you really got to know what you have to do as an ICU doctor. And finally, I will give some general information. So the case at first is one that I borrowed because King's Hospital in Jeddah has just opened its doors, so we did not have that many ICU patients yet. So this is a case from Tokyo, Japan, and the Nakamura and colleagues describe 35-year-old women with no relevant medical history, so with a blank medical history. And she presented in their clinic in the emergency department at first, and then in the ICU with seizures since 5 days, generalized seizures, and quite a lot, like into the tens, even to hundreds a day. And this woman had no relevant history, and they tried to abort the status with midazolam, various anti-epileptic drugs, including phenytoin, levetiracetam, sedation with propofol, but unfortunately all to no effect. And this is really a typical example of a new onset epilepticus that is very refractory to treatments. So about the status epilepticus, you might be familiar with the definition that a status epilepticus is at least 30 minutes of continuous seizures or non-continuous seizures without being awake. But this is not really a practical definition. I think that in daily practice, if a seizure is longer than 5 minutes, then we got to really consider it a status and treat it accordingly. And of course, there are many different types of status epilepticus, and this typical one of these cases was a generalized tonic-clonic seizures. So the seizure that we all have on our mind when we think of epilepsy. So the colleagues from Japan, they wanted to know the cause of the seizure activity. So they did a lot of diagnostic procedures, including blood work. They performed an MRI of the brain that showed typical cytotoxic edema. So you see that at the yellow arrows, you see the whitening on the FLAIR images. So this is apoptosis. So this is actually cell death because of the continuous seizures. They performed a continuous EEG that showed the typical pattern, the so-called periodic discharges. I will show you an example of that. They drew CSF, but no cells, normal glucose and protein, and they did quite an extensive immunological workup, including various antibodies, anti-NMDA, for example, and quite some more. So here you have an example. This is from another publication of the periodic discharges, which is quite a typical EEG pattern of generalized epilepsy. So the role of continuous monitoring in these cases is to detect seizures that might go unnoticed at the bedside. So many seizures, we don't even see them when we are observing the patients. So that's one goal of the EEG. And second, if you start phenobarbital or propofol, so sedation, the EEG can be used to monitor the sedation. And of course, the EEG can also be used for like a prognosis. So what we have here is a new onset refractory status epilepticus, or also called NORSE. And when these cases are preceded by fever, the term FIRES is used. And FIRES is originally a term from child neurology, but there are also adult cases of fever followed by a continuous status epilepticus. And in some of these cases, we know of a cause, for example, an autoimmune disease or a herpes encephalitis, but in many cases, we don't. So there are studies, retrospective studies, and in about 50% of cases, they know the cause, they will know the cause, but many others will be just cryptogenic or idiopathic. And here you see a known series from neurology, from Gaspar and colleagues, and you see all the different antibodies that they found. And for example, also Shriat or Hashimoto's disease. So mostly are immune or autoimmune cases. So it's always the question in these cases, if this is this like cryptogenic or not. That's always difficult. When should you stop doing your diagnostic procedures? And there is a very nice website of the NORSE Institute, and they developed a beautiful algorithm. And the algorithm leads you step by step through these cases. So the algorithm leads you to different tables, and all the different tables, they show you what step-by-step evaluations and investigations you have to do. So this is a very useful website and algorithm to use in these cases. And this is an example of one of the tables that has been added to the algorithm, and that shows that if there are specific neurological features, for example, Parkinsonism or ataxia, that can point you into specific causes of the status epilepticus. For example, anti-DPPX encephalitis, or like anti-emphysine antibody encephalitis in cases of stiff person. So this table and this algorithm is really helpful for you to go through these cases. And the message is, don't give up too early. Don't say that it's cryptogenic too early, but really go for thorough evaluation. And whether it's cryptogenic or not can even also be predicted by this score, the so-called predicting cryptogenic NORSE score. And it's simply like a calculation. And the colleagues also used the score in their patients and came up to a score of 6. And they concluded that this probably was like a cryptogenic case. So back to the case, the seizures were treated with thiopental, midazolam, all to no effect. A variety of anti-epileptic drugs. You see them mentioned here on the slide. They gave high-dose steroids. They gave plasma exchange. However, the patients kept on seizing. And in the meanwhile, one of the lab results came out, and that was a very high interleukin-6 in the cerebrospinal fluid. So probably saying that this case has like an underlying immunological cause without saying what specific cause that might be. And what they did is that they treated the patient with a selective anti-IL-6 blocker, tocilizumab, and then they had a spectacular results, because what you see here in the slide is that in one of the upper rows, you see the CSF EL6, which is high in the beginning, and at day 70, it's quite low. That's the effect of the tocilizumab, but you also see like really that the seizures, that they disappear. So this patient needed a lot of anti-epileptic drugs and sedation, and finally tocilizumab, so the anti-inflammatory drug, made a difference in this particular case. And what the colleagues did is that they reviewed the literature on similar cases treated with tocilizumab. There are several, not that many. And in some, they really had like an effect on the patient. And you see the modified Rankin scores on the right. Not all came out that well, even some died. But there was also like a treatment effect of this particular drug. So some general information on the NORSE. It's a rare condition, and I would say that all hospitals in the world, they might have 1 or 2 cases themselves. They usually stay in the ICU for quite some days. There's quite some mortality, running up to 27% in the adults, and the outcome is usually quite poor. So a lot of patients suffering from a vegetative states or a very poor functional status. And the reviews that have been published are all from the most recent years. So there is recent attention for NORSE. So if you look on PubMed, you will find quite some recent reading material. So underlying, from the interleukin-6 of the case, we know that it might be inflammatory, and the idea is that because of an inflammation or an infection, the brain derails, that there will be seizure activity, and the seizure activity will even worsen the inflammation, and that you have like a down cone cascade with more and more epileptic activity, leading to like chronic epilepsy. But this is all like a hypothesis on what might happen. And the doctors, well, they try a lot of diagnostic procedures. You see that here in the figure. So you see there in the upper rows that nearly all patients get like a CT or an EEG, and of course a lumbar puncture. And if you go down in the rows, you see that genetic testing or SPECTs are even rarely done. So this shows that the patients get at least part of all these procedures, but certainly not all. And I would certainly say that you might use the algorithm in these cases for like a stepwise approach to the patients. And finally, this is like a quality of life study among patients and their proxies. And here you see that the causes of NORSE is very devastating. So there's a huge effect, like on social functioning and emotional functioning in these patients. So the quality of life is really quite poor. So what can we learn from this case? So one is that NORSE or FIRES is a super refractory cause of epilepsy, and it usually requires like multiple anti-epileptic drugs and even sedation and immunotherapy. And NORSE needs to be addressed in a systematic way. So the algorithm from the NORSE Institute can be very helpful to solve these cases. And I would say that don't conclude cryptogenic too early, because there are many even treatable causes, like including like intoxication or paraneoplastic causes or autoimmune disease. And in the case that was shown, like the interleukin-6 really made the difference. So this is the case I would like to present, and maybe there are some questions right now.
Very interesting, Dr. Bastian. Thank you very much for this nice presentation. Fadel, please, if you modulate.
Thank you, Dr. Bastian, for your interesting case. And we have one question from one attendee that is asking about what you think about the treatment controversial. Would you better prefer immunotherapy, ketogenic diet, or high dose of anti-seizure medication based on your experience?
Wait, can you repeat that question again?
There is ongoing debate about the best first line of treatment for the NORSE and FIRES. Was it immunotherapy or ketogenic diet or high dose anti-seizure medications? What is your experience in this?
Well, anti-seizure medication, of course, is symptomatic, and the anti-inflammatory medication treats like the underlying cause. So there are different mechanisms of action, and I think that you use them simultaneously. So you use the anti-epileptic drugs and the sedative drugs to really treat the epilepsy, but the epilepsy is symptomatic, so there's an underlying inflammation. So I think you also need like the anti-inflammatory therapy. Tocilizumab is an example, but there are other examples. For example, rituximab is a well-known anti-inflammatory drugs. All the cases, it's all cases that have been published, so there have not been like real studies on this. So it's mostly like expert opinion. But I would say that it's you use like a combination of the three. So sedation, anti-epileptic drugs, and anti-inflammatory treatments.
One more question, Dr. Bastian. There is someone is asking about, is it like MELAS syndrome? If you know, MELAS syndrome is the mitochondrial encephalopathic lactic acidosis and stroke-like episode. This is a mitochondrial disorders, or it is a different entity?
So like a mitochondrial or genetic disease, and that also applies for POLG. That's another example. These are like genetic causes that can also elicit like these cases of very refractory epilepsy. So yes, I think that you also have to screen for MELAS, and I think that it's also part of the treatment algorithm as has been proposed by the NORSE Institute.
Thank you, Dr. Bastian. Last one more question. As you mentioned from your umbrella, that the FIRES are a subset from the NORSE. Do you think it needs to be subcategorized away from the NORSE?
No, I think that the cases of FIRES are the patients that have like very clear preceding fever. But so I think that they are both a part of the same spectrum. So it's epilepsy, severe epilepsy caused by inflammation. And at the one side of the spectrum, you have the cases with fever. And at the other side, you have the cases that lack fever, but like underlying is like an auto inflammation of the human brain.
I would like to thank you again, Dr. Bastian.
You're very welcome.
We answered a lot of questions. If we need a lot of hours, and 4 hours in this interesting. Thank you, Dr. Manzoor, and Dr. Ashraf. Now with you.
Thank you again, Dr. Bastian. Before we conclude, just back to the question of optic nerve sheath diameter by MRI or by CT, Yes, to best of my knowledge, it's there. And there are some comparative studies that compares ultrasound to CT and MRI, measuring the optic nerve sheath diameter to predict the intracranial pressure. And we published recently, and we have Kira Ruba, who is well known in the field of neurocritical care, particularly the use of POCUS. And she is also the leader of the section of neurocritical care in the SICM. Would you like to comment, Ruba?
Yes, very briefly, as you mentioned, there is a correlation. There is a correlation of ONSD with ICP. There is also a correlation between brain ultrasonography and, for instance, the measurement of a midline shift between ultrasound and CT and other factors. However, the general concept is that brain ultrasonography can guide, for sure, maybe to understand the changes, to understand if something is happening, but cannot really replace the other neuroimaging.
Yes, and it gives me pleasure to announce the next webinar of point of care ultrasound, which is next 15th of April. And we have fellowship program for POCUS online with WICCEM to start on June 30. And there are 3 weeks for neurocritical care by point of care ultrasound. I handle the mic now to Dr. Walid to conclude the meeting. Of course, we answered some of the questions in Q&A, mainly for the certificate of attendance, which will be sent to your email, and the record of the session will be available soon after the webinar. Dr. Walid Jassim, if you conclude the meeting, please.
Thank you, my friend, Dr. Ashraf. I would first like to thank all attendants. At one time, we reached 220 attendees apart from the panel. The panel is working very hard for the last 7 months. We want to give you something useful, which is a Neuro-Critical Care Fellowship. Hopefully, this will be started by November or December of this year. We are very happy to receive suggestions and requests from you. Your suggestions will help us to organize a good fellowship program, and your involvement, early involvement, is very most welcome. I will hand the last 2 minutes to our president, Dr. Amr Al-Husseini. Dr. Amr Al-Husseini will give the last statement and also will tell us about the 4 or 5 fellowships. Some of them, 2 of them, 1 of them started and 4 will be started soon. Dr. Amr Al-Husseini, thank you very much.
Thank you so much, Dr. Walid, Dr. Ashraf, Dr. Manzoor, Dr. Kira Ruba, Dr. Bastian, and Dr. Fadel. Very informative webinar today. And we are, as we mentioned, going to do series of these webinars in the next 6 months before we start our neurocritical care program. So more to come. We have already your information because you already registered. So we have your email and probably we have your cell phone number. So we are going to contact you. We are going to send you the certificate. We're going to send you more information about this international high quality, well-structured neurocritical care program. We have more information to tell you next webinars about our board members, the international board member, and the structure, some of the clinical case scenarios, journal clubs, and also MCQs will be presented in the upcoming webinars. So please stay tuned and keep in touch with us if you have any further question. Again, thank you for your attendance tonight. And as Dr. Ashraf said, the recorded webinar will be on YouTube by tomorrow. And also we are going to send it to you with the link. Have a great night.
Thank you, everybody.
Bye.
Thank you.
Bye, everybody.
Thank you. Bye.
Thank you, all of you. Thank you.